Good afternoon. Thanks everybody for choosing our session today. I am really thrilled to finally be moving forward on a project that I have been passionate about for so many years, outcome measures for visual rehabilitation. Outcomes are the end result, but how do we get that end result? An outcome measurement tool. A few years back, a handful of VisionServe organizations, including my own, trialed a small outcome study. And although that study did not provide us with usable data, it did tell us that what we were doing would not work. It wasn't well defined. We didn't have a purpose or goals. We simply chose a rating scale and a couple of activities and started comparing our pre and post data. Another member tried to organize the data, but there was so much inconsistency, partly because we were all using our own assessments. Occupational therapists were using an OT assessment, orientation and mobility using a mobility assessment, and so on. And it was like comparing apples to oranges. This was really meant as a trial, and unfortunately, it never went any further. Last year at the VisionServe conference, I met several people who were interested in developing an outcomes measurement tool. I also had a talk with Ron Chicard, and he agreed to having Envision Research Institute host and analyze the data. This was pivotal in our ability to move forward. The team has been meeting for about a year, and I just want to share a few of the elements that we've addressed. The purpose. Why are we doing this? We set goals and timelines. We looked at several existing assessments and discussed what we did and didn't like about them. We then had to decide if we wanted self-report or observable task analysis. We decided on both. We chose a rating scale that we felt most professionals would be familiar with. And then for consistency in administering the assessment, we wrote specific instructions. All of this and try to keep it short and simple. We know that people are busy and we didn't want this to be a burden. So we decided on the fewest tasks that would give us the most information. We also wanted this tool to be multidisciplinary. So questions and tasks needed to encompass everything from reading to mobility. We feel we've developed a comprehensive tool that will allow us to collect meaningful data, validating the effectiveness of blindness and low vision rehabilitation programs. Now, if you ask anybody in the field, regardless of their discipline, they'll tell you that what we do does work. But how do we prove that to our funders, the government, families, and healthcare providers? If you look for good outcomes on vision rehab, you won't find much, but the ones you do find show that rehab works. Some of these studies include evaluating the value of low vision services, Veterans Affairs Low Vision Visual Functioning Questionnaire, clinically meaningful rehabilitation outcomes of low vision patients served by outpatient clinical centers, and meeting the challenge of vision loss in the United States, improving diagnosis, rehabilitation, and accessibility. However, there just isn't enough data available. We believe that having a multidisciplinary assessment tool will give us the opportunity to collect and analyze meaningful data that could make an impact on our field by setting standards, promoting awareness, and increasing funding opportunities. We are so pleased to present to you information about the VisionServe Alliance Blind and Low Vision Rehabilitation Services Outcomes, RSO. Of course, we're only in beta testing right now, but we feel strongly that we're moving in the right direction. And I hope you'll agree and consider participating when the time comes. Now, I would like to introduce our dedicated and hardworking team because many of them are not on this panel, although some are in the audience, I'm told. So I'm Denny Moyer, the Executive Director of the Ensight Skill Center for Low Vision Rehabilitation. We have Jenice Heck, the Vice President of Vision Rehabilitation Services at Lighthouse, Louisiana. Kendra Farrow is in research and training with the National Research and Training Center at Mississippi State University. Nilima Tanna is an occupational therapist with a specialty certification in low vision and is a certified low vision therapist who was working for a nonprofit when we started this project, but is now in private practice. We have Dan Norris, and he is the Director of Adult Services with the Vermont Association for the Blind and Visually Impaired. Michael Williams is with the Veterans Affairs Blind Rehabilitation Services. Jared Reyes, Research Program Manager for Envision Research Institute. Ron Chicard, Executive Director of the Envision Research Institute. Tammy Owens is the President and CEO of Visually Impaired Advancement. And Carmen McLean currently works for the Lighthouse, Louisiana as a low vision occupational therapist. And now I would like to turn it over to Jenice to tell you more about our purpose and goals.
Thank you, Denny. As she said, I am Jenice Heck. I am the Vice President of Vision Rehabilitation Services at Lighthouse, Louisiana, and I am blind and an occupational therapist by trade. Some of you might recognize me as Jazz from the Ensight for Blind channel on YouTube. I'm here to talk to you today about the purpose of the RSO. In Mark Freed's presentation on branding yesterday, he said that your brand allows you to engage your audience on a discussion of why you do what you do and the outcomes of that. On Monday, Lee discussed outcomes as part of our 3-year plan surrounding the theory of change. Throughout the conference all week, we've been hearing about the importance of outcomes. That word keeps cropping up. Why? Well, it's because outcomes are necessary to show the value of our services. Do we feel that vision rehab programs impact people's lives in the same positive manner as other rehab programs? Yes, of course we do. But what's the difference between vision rehab programs and other rehab programs? Well, OT, PT, and speech therapists are part of a medical model. We all know that the medical model focuses heavily on research. They need this in order to validate what they do and to show the reliability of the methods that are being used. We know that our programs are effective and meaningful, but we cannot expect people to just take our word for it. And anecdotal data is just not enough. The purpose of the RSO is to provide a starting point for us to come together to validate the impact of vision rehabilitation services. And when we do this, we're going to be able to increase awareness of the benefits of vision rehab services, promote careers in the field of vision rehab, increase referrals, and open avenues for funding from federal, state, and local entities. For example, if we ever hope to be reimbursed from insurance for O&M services, VRT services, or CADIS services, we are going to have to work together to show the impact of what we do. Will this mean more work for everyone? Yes, because we cannot achieve this goal without all of us investing a little bit of time and energy into it. But we've been working hard to minimalize the here. No one wants to do extra work, we get that. But the RSO committee is dedicated to ensuring that the RSO process is going to be as efficient as possible and as streamlined as possible. We know your time is precious and we know your resources are stretched. We get that. So please trust us that we've got that in mind and we're going to make it the best it can be for you. We want you to feel good about this and to be motivated to do it. We need to all think about this as an investment in the future of the field of rehabilitation. We can choose to continue limping along with funding and little recognition for who we are and what we do. That's always a choice. Or we can come together to make a statement and show the world what we're worth. These are really exciting times, you guys, and it has been an honor to be on this committee with such dedicated professionals in the field who have a vision for what needs to be done and how to. It's been really incredible journey. We know that we still have a long way to go, but we finally seem to be headed in the right direction to make it happen. And with your help, we know that we're going to get. So now I'd like to discuss the 4 goals of our committee. The first being to establish a single measurement tool that can be used across professional disciplines to quantify the functional improvements of education and training programs. So we felt that it was really important that we have a tool that was not discipline specific, because as you guys know, every vision rehab program is created differently. Some people use OT, some people use VRT, some programs are just O&M. But at the core of it, at the foundation, there is a foundation of knowledge that we're all working off of. And that's what's important. So with this tool, the examiner just has to have formal education in vision rehabilitation. And that's what it takes in order for us to get the pre and post data. Goal 2, establish a centralized place for collecting and analyzing the data. And this is where Jared and Ron come in with Envision. We have been so fortunate to have them as active members on the committee. They have met with us on a weekly basis and have been able to give us guidance. And they're going to be the key to making sure that this tool has the validity and the reliability to give us meaningful data that's going to help us to achieve our goals. Goal number 3 is to educate program managers, such as yourselves, on the importance of collecting pre and post data. And that's what today is all about. You guys are the very first to hear about what we've been doing and where we're planning to take the RSO. And so your call to action after today is to talk about it. Bring it back to your agencies, talk to your teams, talk to your colleagues, talk to other program managers in the field, and share with them about this exciting resource that is on the horizon for the field of vision rehabilitation. We still have a couple of years before it comes out and it's ready to hit prime time, but that gives us plenty of time to start laying the foundation. We need your buy-in, we need your involvement, and we need you guys to create the buzz and get everybody excited about this, because it is something to be excited about. It's actually a historical turning point for our field, and we've got great expectations for it. Our 4th goal is to train everyone on how to administer it and how to submit the data. We are trying to do this right and dot all of our I's and cross all of our T's. And we want to make sure that we're creating a tool that's useful, but it makes no sense to just toss it out there and tell everybody good luck. We are going to put systems in place to make sure that everyone who is administering this tool has been trained on how to do it properly and on the quickest and most efficient way to submit the data. So as I said, this is great stuff, guys. We are viewing this as a potential turning point in the field of vision rehabilitation to help grow the field, to help increase funding. We have a lot of benefits to this, but it's going to take all of us there. So now that you guys are excited about being a part of something so special, I am going to turn the spotlight over to Nilima Tanna, who is going to present the initial format for the Rehabilitation Services Outcomes Tool.
Sorry about that. I just realized I was muted. Good afternoon, everybody. Thank you, Jenice, for that. As all of us have heard over the past 3 days, there's a lot of talk about outcomes and measurement. Terry Yanovich, when she gave her awesome talk on culture of excellence, also mentioned that every service organization needs to have service standards. And one of the service standards she mentioned was measurement. So this tool strives to measure the impact of vision rehabilitation programs and services for our adult client population. As a committee, I just want to give you a brief history. We did review literature and all the tools that were available to us to make sure that we were not putting in work for something that was already created. And we were pretty lucky because on the committee, we had people like Mike who shared the LVFQ that the VA uses. I know Jenice shared the comprehensive assessment that they use at the Louisiana Lighthouse. Kendra shared the functional independent living assessment. We looked at the SAFRAP that the occupational therapists use. Ron talked about the TIADL when we were doing the observational assessment. So we really did our due diligence and looked at all the different tools that were out there to ensure that we did our homework. The key points of this amazing assessment tool, I think, like Jenice, I'm biased. I think it's pretty awesome. It's a work in progress. So I'm sure that there'll be quite a few tweaks before you see the final version. But the key points is that this is not a replacement for discipline-specific tools that staff uses in their organization. It is a snapshot of some of the common struggles that our clients have across the disciplines, because like Jenice and Denny mentioned, we didn't want it to be too time consuming. We wanted it to be efficient so that staff was not spending a lot of time on another tool before they could start working with clients. And also, as you must have noticed in the name, this assessment tool will allow us to measure the outcomes with varying levels of vision impairment, all the way from people who have low vision to people who are completely blind. So here it goes. As Denny mentioned, we have two different components to the assessment tool. One is the self-report, and the second one is the observational assessment. We also reviewed quite a few rating scales that were used in the tools that we reviewed, and came up with a rating scale for this tool, and Dan will be talking about that. For the RSO self-report, we have 17 questions that are different tasks under 5 main categories. The categories are personal management, reading and writing, financial management, access technology, and mobility. And so I'm going to share some of the things that are in some of the questions that are in the self-report. For each task, we came up with a task, and then we came up with a task description so that everybody is asking the same thing, so that there is standardization and validity. Some of the questions that we have are, do you have difficulty accessing continuous text? Do you have difficulty accurately paying your bills and purchases? Do you have difficulty using a telephone? Do you have difficulty accessing desired electronic communications? Do you have difficulty finding your way in familiar ways? Do you have difficulty finding your way in unfamiliar ways? So as you can see, we have a breadth of different tasks and activities that we have included in our self-report. The second part is the observational assessments. And for that, we have chosen 4 tasks. They're accessing food package information, telecommunication, making change, orientation, mobility. And For the self-report, we concluded as a committee that we didn't need to have two different instructions for the pre and the post, but for the observational assessment, we did decide to have different task descriptions for the pre-assessment and the post-assessment. And now I'm going to hand it over to Dan, so he's going to talk about the rating scale.
Awesome, thank you. And I just want to echo all my peers and just say how great it is to work with this team of professionals and all of you who are not on the call today speaking. All of us have been very dedicated to the program. I really appreciate everybody's efforts. For the rating scale, before I mention the rating scale, a quote came to mind this morning as I was preparing for this, and I tried to find the source for it. I think it's Helen Keller, but I couldn't find it. So if it's not Helen Keller, we'll say it's from the Book of Dan. Basically, the quote that kept coming to mind today was that the world rarely recognizes the small steps that constitute huge victories in the lives of our children. And I'm pretty sure that was Helen Keller. I didn't make it up. I believe that not only applies for children, that applies for young adults, that applies for adults and senior citizens. The clients that we serve, when they have an incremental step of progress, that is a huge victory in their lives, and it should be celebrated. And also, that progress should be captured and recorded. And so as we talk about the rating scale for the assessment, we talked, as was mentioned, we went through several different assessment tools that are out there. We looked at their rating scales, and we really felt that this rating scale captured what we were looking for. If the scale does not apply to our client for any way, in any way, shape, or form, we mark that it's non-applicable. But what it really measures is the independence with which the client completes the task. So if you have a 0, that means the client is unable to complete the task. If you have a 1, it means they have great difficulty in completing that task. If you have a 2, there's moderate difficulty, and 3 is minimal difficulty. 4 would be that they can independently complete the task. So what this really does is this, as we work with our clients in the pre and then the post assessment of the observational tasks, we're able to show the progress they made after receiving vision services. And that, again, is the key. That's what we're trying to look for here is we want the data to show whether or not vision services result in beneficial outcomes for our clients. So this is the rating scale that we decided to go with. As was mentioned earlier as well, within the instructional material that we give to our testers, they will receive instruction in how to do this assessment, how to determine what is minimal versus moderate. We're going to have examples that are in the materials that we give them to help them to sort out between those two. All of the testers who are going to be doing this will have received a basic baseline knowledge of vision services, so they know their trade. It's a matter of us conveying to them how to go about this in a reliable, similar fashion for all the testing that's out there. On the next slide, again, the people who will be doing this, these are individuals who've gone through a formal university program or have gone through a formal certification program for vision services. And right now with our beta testers, we've had CLVTs and OTs and comms in different parts of the country working for different agencies, beta testing this tool. As they've gone and used them, they've been giving us great feedback. And so we now have a survey that's out to them right now that's collecting some basic information. Some of that information is, was the instruction clear for the clients with the self-report? Was the measuring scale clear to the client? And how long did it take you to accomplish the task? The same is true for the observational assessment portion. We're asking if the instructions were clear, if the rating scale made sense, and how long it took to do that as well. You've heard us say several times here, we're not looking to add a great burden to anybody who's going to be piloting this for us. We want this to fit into what you're doing. We want it to be, not be an extra burden. The demographic information that we need to collect along with this, we're making sure lines up with what you're collecting already for the older individuals with blindness program. We're making sure that we're not going to be asking more of you than you are already doing. It's going to fit into how you're doing it. And we're asking our beta testers to give us feedback to make sure that that is the way that this is ending up. We ask them to make sure that if any parts of this felt like it didn't apply to them as a vision professional, we're asking them to give us that feedback as well. We don't want this to be an uncomfortable fit for people who are out in the field, practicing this. On the next slide, so right now we're in the phase 2. That's where the beta testing is happening. We're collecting the data, we're looking at our tool, we're refining it, we're making sure we're getting the right demographic information, we're getting that feedback. The next phase after this, in phase 3, will be to reach out to university programs. And several of them have already said that they're willing to take a look at the tool when we've got it at a point to actually take a look at it. And they're going to give us feedback, help us refine it a little bit further. And then they'll help us with the integrator reliability and advising us on how we can roll out a program that's going to prove that this tool has validity. So over the course of next year, we hope to be able to work with these university programs to really, to get it, the IRB and the validity of it established, so that in 2022, we can roll it out to our entire VisionServe Alliance community and beyond, to be able to have professionals get this in their hands and to begin crunching that data. And that's where Envision comes into play. We're so grateful that they're willing to be the ones to collect the data, to show the validity, to be able to make this a tool that will make a positive impact for our field. And so I just want to thank everybody that's involved in that. And I guess that I'll turn it back to Denny and the group. I think we're at the question portion now.
We are. So if there are any comments or any questions, we're open to that.
Yes, let me open up the questions here. From Jacqueline Bouchard says, are you still looking for agencies to beta test? How can we get involved?
Yes, we are. We're always open to more agencies that are willing to work with us, especially now, so that we make sure when we roll it out that we've got good information. And, as we've said over and over again, that it's not going to be a problem for the people who are giving the assessment to do something else. So we want to make sure that this blends in well with what everybody's doing. Give us a call or send us an email. You have our contact information. Feel free to let us know as soon as possible, and we will get this information out to you.
I have a comment and a question from Deborah Gold here. She says, in Canada, the national VR programs and in New Zealand, they have adopted the COPM as their outcome measurement tool. How do you think, what do you think of this option in contrast to this specialized tool?
COPM? We'd love to get a copy of it. Could you send it to us?
I'm sure that can be arranged.
It's actually a tool that's being used by occupational therapists. It's the Canadian Occupational Performance Measurement, but it's pretty comprehensive. And so it's a tool that I'm familiar with, but in order for us to, it's pretty subjective, and it's a very good tool, but for the client population and for the purpose and the goals that we established, we didn't think that it would meet all the goals that we had.
This is Dan Norris. One of the challenges that we had as we were going through the existing tools, many of the occupational therapy tools were really good and very comprehensive, but we found didn't necessarily address blindness specifically. A lot of it dealt with low vision, and we want to make sure that we're getting the full spectrum of vision loss and the benefits that come from vision services. I don't know if the COPM addresses blindness specifically, but that was one of the things that the rest of the crew can talk about as well, that we kept encountering, was that sometimes the tools didn't address blindness. It addressed low vision, but not blindness.
Very true, Dan, and that's true even for SAFRAP that we use
Mhm.
as occupational therapists quite a bit. The tasks and the task descriptions are very low vision friendly.
Yeah. And they're great. They're absolutely great for low vision. It's just a matter of we also need to address the blindness as well.
True.
And is this tool able to be piloted in Canada with Canadian members?
Sure.
I don't see why not. Yeah.
Absolutely.
Yeah.
Absolutely.
In fact, it would be great to have, international information, especially since you're already using a different tool. It would be kind of nice to see how this fits into what you're already doing.
We want this to be a tool that is useful to everyone. And so if we can get more voices, to pilot and help us through the process, it's just going to make it a better tool. It's going to make it stronger, and it's going to make it more accepted by more people. So we appreciate those offers. Absolutely. Please reach out and let us know if you're interested in being a part of the process.
And again, the end result is for us to get as much information that can be, analyzed and published to show that, hopefully to show that what we're doing is outstanding. And that's true, across the world, where there isn't a location where people aren't visually impaired, blind. And so, we want people to know that these programs do work. So the more information we gather and get to Envision and to Jared and Ron, the better. More is better in this case.
Patricia Sykes asks, how will the launch of the final product be made, and how or where will it be accessed?
Patricia, I like the way you think. That is awesome. You're a forward thinker. The answer is we don't have all those details yet because we're not at that part of the process. But we are planning to be sure to get in front of as many of you as possible as it gets closer to being ready. We will be at all of the conferences, whether it's an Envision conference or a VSA conference or all the other conferences in between. We're going to have a presence there to make sure we get the word out and that that everybody has access to the tool and the training on how to administer it. And we plan to make it as easy and efficient as possible. We just don't have all those details yet, because right now the focus is on making sure the tool itself is sound.
And Patricia, one of the things that we're working on right now is to make sure that the tool is user-friendly for the professionals that are using it, so that it's not a lot of verbiage that they have to read, but that the instructions are clear and concise and more like a one-pager that they can carry with them. So that's the part where we're at.
Mike Walsh says, I really like what you're doing here. I like the simplicity and brevity of the tool, and thinking about measuring outcomes in our organizations have been struggling with the question of whether a tool based on an assessment is as valid as a tool based on clients' actual goals. The former is based on the outcomes of your choosing. The latter is based on the outcomes of the client's choosing. I'm very interested in any comments you might have.
Well, we decided that we couldn't just have self-report straight from the client. This tool is designed to incorporate a little bit of everything, because sometimes there's a disconnect between the client's perceptions of their experience and knowledge and what the professional is observing. And so we tried to bring all of that together in a nice compact tool here. And so, so thank you for bringing that up and for asking. We're doing our best to make sure that the information that we're capturing is meaningful in the field. And it incorporates both the perception of the clients that we serve and the observations of the professionals.
Right.
And that's going to give us a lot of information, because if we observe the opposite of what the client reports, that and that's happening consistently, then there's something wrong in how we're delivering the services. And so by capturing both, we'll be able to see that trend of not only us observing that they're becoming more independent, but them also observing that as well. The data is going to tell us this is beneficial. We think it's going to tell us it's beneficial. We know it's going to tell us it's beneficial, but the data is going to ultimately tell us that it's beneficial. So.
And I think that as far as the patient goals are concerned, because both the self-report and the observable tasks encompass things like reading and assistive technology and, or telecommunications. I mean, we're mobility, we're trying to touch on all of those areas, so that if their goal is to be able to, read a grocery list or whatever it is they want to be able to do, that we'll be able to show that through rehab, now they have their techniques lined up to be able to accomplish whatever independently. So we really feel that by having both, we will be including, or it will be inclusive of pretty much all the goals.
Yeah, and just to piggyback on Denny a little bit, and that's why with the rating scale, we decided to have a NA, so that if, for example, for any meal preparation task, if it's not a goal for the client, they can just say, it doesn't matter to me. And that's our way of kind of like taking their goals into consideration as we do this assessment.
Great.
Very good. You guys are keeping people interested. I got lots of questions rolling in here. Neva Fairchild asks, are you going to collect rehabilitation training hours to compare to outcomes?
The training hours, we didn't really talk about.
We didn't talk about that. Yeah.
Think of that. What a wonderful idea. We're going to have to add that. I'm going to add that to the agenda for our next meeting right now, because that is a really good idea. We're going to talk about that. Thank you for bringing it up.
She also asked, did you look at the Teresa Smith tools? This sounds very similar.
We did not look at the Teresa Smith tool. I've seen it in the past, but no, we did not. That wasn't in the mix of the mainstream tools that we were looking at. Yeah, we were trying to choose the ones that are most commonly used across the board and as our starting points. And so, no, I do not believe that one was one that we had looked at closely.
Yeah.
And with all the tools that we did look at, they all had some consistency in the questions that they asked. Because we're all working on the same activities, basically, regardless of the patient's goals. They're, again, reading and technology and communication. And so I think all of the ones that we looked at, some were longer, maybe the question was longer, but they all addressed pretty much the same thing.
Mm-hmm.
There wasn't one that was comprehensive, though, for all the disciplines.
That was time efficient. There were some that did, but they were very, very long.
Yeah. I neglected to mention something too, in terms of phase 3, and that is once this is out in the community, we do intend to publish the results, to put it into journals, to get the peer review and so forth. I wanted to make sure I mentioned that we do have the long-term goal of this being published on the other end as well. I neglected to mention that, sorry.
And then I'm going to retire.
Yes.
Got a question from Jackie Bouchard that says, are there opportunities to modify the tools? Can the provider skip sections in the self-report or observational assessment? And if a provider is only providing AT services, can they eliminate the O&M sections?
No, not at. Go ahead, Dan.
Yeah. Well, so because we wanted to have this be transdisciplinary in its approach, the O&M task that's built into the activity is fairly simple. It can be modified if the person is going to be using crutches or a walker or a wheelchair, things of that nature. So we are taking into account the adaptability of it based on the client's circumstances, and built into the instructions are, for example, if a client is not yet a Braille reader, but that becomes one of the goals, the Braille can be the way they read something. Scanning something can be the way they read something. So it's designed in a way where it should be able to be done by anybody, even if they themselves are not providing the service that it's measuring. But then somebody else provides the O&M services, and then on the other end, you see how they function, having received the orientation mobility services. Hopefully that makes sense. Even if you may not be the provider providing the O&M, you can still provide the observation of how they get from point A to point B.
So basically, we picked tasks that are very common daily tasks that most human beings would need or want to do. And so that's important. We're not down in the detail of being able to be a master chef in the kitchen or anything like that, because that doesn't speak to everyone. But the tasks that we chose, we feel are very common tasks that your average person would need or want to be able to do. And so we're using those tasks to gather the information pre and post on how their skills and knowledge evolve through the rehabilitation process. So where's their starting point? Where's their ending point when we're done, to show the outcome?
And also for research purposes and gathering of the data and vision, it's best to have the whole test completed as the whole assessment completed as it's listed.
From Patricia Sykes, can this be used for assessing remote services?
Certainly. I mean, I'm going to add that to our agenda too, to talk about. It's designed to assess the rehab process, the vision rehab services. We don't define what those are supposed to look like. So I don't see why virtual wouldn't be a part of that.
Yeah.
So it would be interesting though to know if you see a difference between virtual versus in person. So that is that's a good thing to consider. Thank you for bringing that up.
Yeah, thanks, Patricia.
Yeah. And as with most things, we started this whole process before COVID-19.
It's true.
So.
I had a question from Donna Sue Sullivan. She says, are you addressing auditory and tactile discrimination skills pre and post?
So this assessment is more task oriented. And so whatever strategies the person uses pre, and then whatever they learn from us in rehabilitation, whether it's tactile or auditory or whatever, to complete the task post, that's how we want to be able to show outcomes. So I hope that answers the question. I think this assessment is more geared towards tasks.
There's lots of skills. Yeah, there's lots of skills involved in completing the tasks. And they are going to be allowed to use whatever skills they develop over the course of the vision training to complete the task. So, yeah.
Very good. I've got a scenario here from Deborah Gold. She says, a client calls in and subsequently is referred to 2 or 3 services. So what would this tool be administered at intake? At one point in the process, I was thinking about what is conducting, I'm sorry, I'm reading poorly. I'm trying to think about who is conducting the observations and when.
We're still working on it, right? Am I correct, Denny?
Well, I think just for clarity, the way this is designed is that whoever sees the client first will be the one to do the pre-test for this tool. And that might be an OT, it might be an O&M. But as long as it's someone with formal training in the field of vision rehab, that person should be able to do the pre-test for the self-report and the observational piece of this. And then the person, the client, will go through the rehab process, and they'll finish their OT services, and they'll finish their O&M services, and they'll finish their VRT services. Whoever the last professional is to close out that client in through the vision rehab process, the last person to see them and do a discharge, that's when the post-test data will be collected. And that person might be a different examiner than the one who initiated the process, but that's okay. That's okay. As long as it's a vision rehab professional, we feel that we'll be able to capture the data that we need. Does that help? I hope that brings clarity to how it works.
I think so. Well, very good. Well, I don't have any other questions here in the queue. We'll go ahead and give just a minute or two for people to roll in any other final questions they might have. Are there any links or resources that you're able to share with this audience that might just kind of help them understand a little better or just get involved a little more?
I think contacting us would be the way to get involved more.
Right.
And as we work with the universities, we'll be designing the training modules that will be involved with helping people learn how to use this and roll it out beyond just the beginning beta testing that we're doing right now. We're getting feedback right now from people that are going to help us design that instructional material for the next wave.
So I think it would be helpful if any of you or your agencies would like to help in the process of piloting. If we need to reach out and get more information, get more help from you guys, that would be awesome. We would love that. Maybe the best way to do this would be for you to reach out to Denny as our fearless leader.
Yeah.
And she can collect the information, and Denny's email should be in their profile, right? That was presented. Okay. So email Denny if you're interested in helping us with this process. We would love your input. Again, we really, we love the involvement. I hope you guys are as excited as we are about this. This could be a really big thing for our field to help us grow the field, to help us validate the field, to help us get more recognition, more validation, and of course, more funding down the road. So we really appreciate your helping us with this to spread the word, keep the conversation going, and get involved. Thank you.
Yeah, thank you.
Fantastic. I got one more question that came in here from Mike Walsh. How long does it take to administer this assessment?
We are currently working on that through the beta process. So we've gotten a couple of different numbers from different people. We'd like to gather more, have more tests to get a better average. So right now, I think it's, what was it looking like, Nilima? Was it around
20 to 30 minutes?
Yeah, really depending on the examiner. But that's for someone who's doing it for the first time or second time. I mean, as with any assessment tool, once you understand how to do it, you know, your time gets cut significantly in administering it. So the more information we get from our beta testers, the better answer we'll be able to give you on that. But I assure you, we are trying to keep this as quick and efficient as we possibly can without sacrificing the information that we need.
Right.
So,
and on that end, we are clarifying the instructions and making them more concise so that it's easier for people to understand what they're asking the client to do, making it a little bit more user-friendly for the professionals.
Right. That's where the
That's a great
survey
question,
came in.
Jill.
That's going to make a big
Yeah.
difference. Mhm.
Well, thanks for joining us. This is great, and we appreciate your input. And I've written down the great ideas for our next meeting to add to our agenda. And thank you all for joining us today. We really appreciate it.